Good afternoon, everybody. Thank you for coming. My name is Julie Fisher. I am the chairperson of the Fitness, Health, and Wellness Committee. We have brought you this opportunity to hear from the Practice Sunshine Rheumatology and Arthritis Center today. And we present you with Dr. Vedashree Panthulu. She's been serving the Sun City Center community since August 2017. She's founded Sunshine Rheumatology in 2018. You're board certified in internal medicine and in rheumatology. Is that correct?
Yes.
Okay. You chose rheumatology because it's intellectually challenging and exciting. Recent advances in the treatment options include those on the horizon. They add enormous gratification to your patient care. You strive towards improving the quality of life for your patients. You are in the Lakewood Ranch, Venice, and Sarasota area, so you're one busy MD. So, in addition to our lecture today, I just wanted to let you know that you maybe have seen through the newsletters over the course of the few months that our Fitness, Health, and Wellness Committee has been very busy bringing you guest lectures. We're going to take a little summer hiatus. We have found that a lot of people, even though they stay here, they travel a bit. So we're still going to have 2 guest lectures from our own panel of people on our committee. We've got Dr. Andrea Adler, and she's going to be talking on one of 2 subjects in the month of August. And then we have another MD on our committee. His name is Jason Soro, and he's going to be talking about water quality, possibly osmotic water, and that'll be in July. Then in addition to that, we're going to be doing this is for you, Ted, a Healthy Bites contest where you have to prepare a recipe that people can come in and judge the taste of your food, but it has to be a healthy item, such as maybe low sodium, low fat, maybe ingredients that people might not have been used to, but the focus is healthy. So, without further ado, I present you with Dr. Panthulu. Thank you so much.
Thank you. Yeah, I knew that the crowd is going to be small, so I didn't create any presentation. I just want to be spontaneous. I do want to reserve some time for questions and answers, So not many people know what a rheumatologist is. So rheumatology is the medical counterpart of an orthopedic. So orthopedics are the ones who are replacing the joints. They're the surgeon counterparts for us. Like if you have a heart attack, you don't go to a cardiothoracic surgeon directly. You go to a cardiologist first, who then tells you that you need a bypass surgery, then you go to the cardiothoracic surgeon. So for those reasons, if you have joint pains, you need to first visit the rheumatologist rather than the orthopedic. I know usually most people go to the orthopedic, but then they're pretty good if they think there is an underlying autoimmune disease, they refer the patients to us. So as rheumatology, we get trained in internal medicine for 3 years and then 2 years of fellowship in rheumatology, where we are trained mostly about autoimmune diseases like rheumatoid arthritis, psoriatic arthritis, PMR or polymyalgia rheumatica, giant cell arthritis. These are very common conditions affecting elderly population. So we do see a fair bit of those diseases. So I want to touch on topics that affect the elderly population, symptoms that you should be aware of so that you can come directly to us. Many a times, the patients have classic symptoms of polymyalgia rheumatica or PMR, and patients just assume this is me getting old, and they don't visit the doctor for a long time. And even when they go to the primary care, sometimes the primary care doesn't know about it. Some do, some are very astute and they will diagnose and they will start the treatment, but some are not sure. They will order labs that will delay further treatment. So I want you to be taking away some of the conditions that you should be aware of, so you can tell your friends, your family that, hey, this is a condition I heard about. You need to go see a rheumatologist. So I hope that's the takeaway from my presentation today. So one of the most common conditions that affects everybody is arthritis. The 2 common types that we differentiate mostly is the regular arthritis, which everybody gets it after the age of 60 usually. But if you have any trauma could be micro trauma or a major trauma, that arthritis sets in much quicker because the cartilage is damaged, the joint is damaged. And once, unfortunately, these are all chronic conditions. There is no cure for it. It's not like an infection. You take an antibiotic for a week, you're done, you're cured, you're healed. All of the rheumatological conditions are unfortunately chronic, and they need management on a day-to-day basis. So arthritis, we like to differentiate between inflammatory arthritis and regular arthritis or degenerative arthritis, which is wear and tear, injury, and trauma related. So if you have any inflammatory arthritis, which is the symptoms are inflammation, so the patients will present with swelling, stiffness. Everybody after the age of 60, I expect some stiffness. When you get up in the morning after a good night's rest, you will feel stiff. You will not just get up and go. You will stretch your body. You will take some time to loosen up. What is normal? Up to 30 minutes is considered normal. Gelling, it's called the gelling phenomena. When you sit for a long time, your joints gel up. And it can take up to 30 minutes, but most commonly, most people loosen up within 5 to 10 minutes tops. But up to 30 minutes is also considered common. In inflammatory arthritis, that stiffness, that feeling that that the joints are not mobile, they are robotic, they have to stretch, that takes about an hour or more. It is usually associated with joint swelling. You're not just feeling swollen, but the joint actually looks swollen. Redness is not a big feature of inflammation. Redness, if I see redness, I'm more worried about cellulitis rather than inflammation. You will see some, definitely you will see some warmth when you compare it to your other normal joints, and you will see stiffness, swelling, joint pain out of proportion. And inflammatory arthritis usually affects in the morning. The pain is usually worse in the morning. Some of the symptoms that I ask my patients are, how long have you been stiff in the morning? How long does it take you to loosen up? When you wake up, do you feel like a 100-year-old or do you feel 60? And when you move, do you feel better? Does the pain get better as you move? Osteoarthritis, on the other hand, the more you move, the more you hurt because the joint is damaged. It's usually more at the end of the day. The pain is at the end of the day. The rest makes it feel better. Sometimes it can be swollen, especially the knees. You can have swelling in osteoarthritis as well. Some warmth associated mostly with knee arthritis again. So these are the main classic features. When you have an inflammatory arthritis, you wake up, you're like, I am 100 years old. The mornings are the worst time. The more you move, the better you feel. And then mid-afternoon usually is like the best time of day. So one of the symptoms which you need to be aware with inflammatory arthritis that affects the elderly is called PMR or polymyalgia rheumatica. Nobody below the age of 50 will ever have it. If the age is 48, PMR is out of my differential. I would not even consider PMR as the diagnosis for that patient. So you have to be above 50. Unfortunately, 70 and 80, the incidence increases much more. And patients, because patients are usually old, they feel, oh, I'm just aged overnight. I'm feeling just old. But no, it can happen suddenly, like within a day, like one day you wake up and you're like, oh my God, I'm feeling much older. Or it can slowly develop on you, and it usually affects the hips and the shoulder muscles. So it's a proximal group of muscles. Classically, my patient will say, I can't get out of the bed. I have to sit, stretch. It takes me a long time to get out of the bed, get out of the toilet seat, get out of the car seat. I can't lift my shoulders above my head. I can't reach into my kitchen cabinet. I can't brush my teeth or comb my hair. All of that is worst in the morning. Mid-afternoon at 12 o'clock, as I keep moving, I feel better, and I am much more improved in the afternoon. So if you ever hear anybody who gives these symptoms that they feel that they have aged overnight or are much more stiffer and pain is worst in the morning, then let them know that they need to see a rheumatologist. This could be PMR or polymyalgia rheumatica. Osteoarthritis pain, at the end of the day, worse with walking, worse with exercise, improved with resting. So PMR is easy to treat. Unfortunately, as I said, none of the diseases are cured. So we have to manage them with the cornerstone of therapy is prednisone. Prednisone, as I tell my patients, it's acutely wonderful, chronically dangerous. if you have to take it. Chronic is anything that you take for more than 3 months. And for PMR, unfortunately, you have to be on it for more than 3 months. So we give you 20 milligrams or 15 milligrams of prednisone, and it's like magic. Patients will say, oh my God, my life is back. So that's how PMR is diagnosed. You're above 50, you're giving me the classic presentation, stiffness and pain and shoulder in the morning, especially in the shoulders and the hips. Inflammation markers, there's a blood test, which is ESR and CRP. If those blood tests are drawn and we see the inflammation markers are elevated, that's another clue for the diagnosis. You can always, if you don't find a rheumatologist, you can always go to your primary care, tell them, maybe I have PMR, draw my inflammation markers, ESR and CRP, and they can at least get started. Unfortunately, there's such few rheumatologists in Florida that sometimes the wait times are busier. We try to keep our wait times under 4 weeks, but some of our offices, have wait times of 6 to 8 weeks. So if we can get you in quicker, your primary can start the management. They are aware, they can at least get the prednisone going. Treatment is prednisone, as I said, 20 milligrams, works like magic, and that's the 4th response answer. Like if you respond magically to prednisone 15 or 20 milligrams, that pinches the diagnosis of PMR or polymyalgia rheumatica. The treatment is, of course, over several months, slowly tapering the prednisone. That's why you're on it for more than 3 months. It's again, you want to taper it as fast as you can, but also as slow as you can. Because if you taper it too fast, you can relapse and we start the process all over again. And if you go too slow, of course, we are putting you at risk for steroid-related side effects, which is, increased appetite, weight gain, water retention, mood changes, anxiety, panic attack, blood pressure goes high, blood sugars go high. When you've been on it for more than 3 months for high doses, 5 milligrams or less is considered low dose, 10 is considered moderate, 20 and more is definitely high. When you're on moderate or high doses, it increases your risk of cataract, glaucoma, bone loss, osteoporosis, avascular necrosis of the joints, hips, and so on and so forth. So that's why we love it and we hate it. We love it because that's the only drug that will immediately help patients. Patients feel magical. So PMR, definitely remember that. And then again, it has a cousin, or many PMR patients in their lifetime can develop something called giant cell arteritis, or GCA. In PMR, the inflammation is limited to the bursas of the shoulders and the hips. The inflammation is not in the joint actually, it's in the bursa that overlies the joint space. So when the inflammation goes into the arteries that supplies the eye, which is the ophthalmic artery, the temporal artery, it's a branch of the temporal artery. So sometimes the inflammation can go into the artery supplying the temporal eyes and the temporal artery. The patients would have symptoms such as new onset headache. It's a new headache, it's not like your regular headache. It wouldn't wax and wane. This is a new onset headache that would not go away. You take Tylenol, you take ibuprofen, it would not improve. Usually unilaterals, mostly temporal, sometimes can be occipital, sometimes can be frontal, but classically temporal. It is tender when you touch there. You can't press on it or you can't sleep on it because it's tender. You can have jaw pain, same-sided jaw pain, because the artery is also supplying the jaw. You have trouble chewing food, you have trouble swallowing, you have jaw claudication. Along with vision, because it's affecting the eyes, you can have blurry vision, double vision, curtain falling before the eye. This is one of the most common emergencies in rheumatology. There are only a couple of emergencies. So vasculitis, which is inflammation of the blood vessels, is the most common emergency in rheumatology. So if you ever develop these symptoms, you don't even wait for rheumatology office or primary office. You go to the ER, you go to the urgent emergency room or urgent care, and you need very high doses of prednisone. PMR 15, 20 does the trick. In giant cell arteritis, you need 60 milligrams, 60. And you stay on it. The tapering regimen is very slow. You're on 60 for a month, 50 for a month, 40 for a month, 30 for a month. You slowly taper it off. Thankfully, now we have some biologics approved for giant cell arteritis. Tocilizumab or Actemra is one of those that is approved, that is given as an injection in the belly or intravenous infusion, that has cut down the side effects of the prednisone and tapering regimen of the prednisone much, much faster. But again, these biologics, as we call them, they come with their own set of side effects and contraindications, so it's a fine balance. This is definitely, the giant cell arthritis is definitely not managed by the primary care. They usually refer to us, and if your primary care has referred you to us but has not written urgent or mentioned clearly giant cell arthritis, when you call us, mention it, this is a giant cell arthritis case. These are the cases that I have told my staff that these need to be seen within 1 to 2 weeks. If the patient calls us, they are on 60 milligrams of prednisone started by their PCP or anybody, and then we have to get them in urgently. We have urgent slots scheduled, slots reserved for such patients when either primary care calls me saying that, hey, can you see them sooner? Because we want to keep those slots for some urgent referrals like these. So giant cell arthritis, the prednisone, as I said, is very high doses. Diabetes is a problematic comorbidity when we are using steroids. Patients' blood sugars go so high, like 300, 600. So that's why thankfully we have newer drugs now to manage those consequences. So we do start biologics quickly to get the steroid tapering faster. So these are the two conditions I definitely want the elderly population to be aware of. The other, again, regular arthritis. Unfortunately, there is no cure. Whoever finds the magical pill or magical answer is going to be a billionaire overnight, even if they sell it for a $1 profit. We have billions of people suffering from it. The main goal for arthritis that I tell my patients is managing the pain, getting ahead of the pain, and being as active as possible. The arthritis is not going to go anywhere. Many patients come to me, see me, and then they say, I don't like to take medication. I don't have easier answers apart from physical therapy and exercise. If you consider any joint like a house, joint, muscle, ligaments, tendons, these are the 4 pillars that are holding the house together. When one gives out, the other 3 need to be stronger. They need to pick up the load. So in osteoarthritis, the knee arthritis or back, the joints have given out, the damage is done. There's nothing, unless you're replacing the joint, there is nothing else we are doing to help that joint problem. So in that situation, the muscles, the ligaments, the tendons, they need to be extra working extra hard to keep the house stable. So in that situation, therapy or exercise is recommended. Then patients tell me, yes, I'm active, I'm moving around, but specific to the joint, you want to do those exercises. When I'm active, when I'm walking, how many times am I moving my neck this way? Never. How many times am I going above my shoulder? Never. I'm active, but I'm not doing those exercises specifically. So the joint that is involved, you need to do exercises specific to that joint. For the small hands, when you have osteoarthritis, you need to do these small joint exercises. So there are several, I'm not the therapist or the specialist, so YouTube has special of exercises. I know many of these clubs have access to physical therapists, so you can sit with them. Even if you go a couple of times, 2 or 3 times, learn the exercises and do it by yourself at home, you will benefit from it. I think physical therapy is the most underrated specialty for arthritis because we have to do the effort, we have to exercise. Most people go to the therapy and they say, oh, it did not work. But of course, there is a bell-shaped curve where, certain amount of people are responsive to any type of therapy, they respond beautifully, and there are some that don't respond at all. But I think we should give our fair share to physical therapy, do the effort, do the exercises recommended by the therapist. Most of the times we don't, we do a half-baked attempt or half the attempt, or not do the recommended course, and then we say, yeah, it didn't work, and then we're trying for other regimens of treatment. So exercise is the most, even though you are hurting. I know it sounds counterintuitive. My knee is hurting, I will tell you, please exercise. Because if you don't use that muscle, you lose that muscle. So if that's the logical answer that happens. I'm in pain, I'm not gonna move it. If I don't move it, it doesn't hurt me. But you're not moving that muscle, couple of weeks later, months later, that muscle is not going on vacation. It is assuming you don't need me. I'm going on vacation. And then for you to bring it back from vacation, it will take a lot of effort, double the time, or maybe never. So you want to be exercising. Getting ahead of the pain is very important. Many patients, as I said, they're in pain. They say, I can suffer through the pain, but I don't know if subconsciously or consciously you are, avoiding that joint, not moving that joint. So you want to get ahead of the pain. Tylenol or acetaminophen is relatively safe. All my patients, I tell them, you can take the full dose of Tylenol in a day is 4 grams or 4,000 milligrams. If you're taking extra strength, that is 8 tablets in a day. If you're taking Tylenol Arthritis, that is 6 tablets in a day. Regular Tylenol is 12 tablets in a day. So if you can be below the limit, I'm not recommending you take 4 grams. On a bad day, yes, take 4 grams. On a day-to-day basis, take at least 2 grams to 3 grams a day, finding the right regimen if it works for you. Do 2 tablets extra strength or 2 tablets Tylenol Arthritis 2 or 3 times a day on a day-to-day basis and see if that improves your pain score. 20-30%, and clinically if it is impacting you where you're saying, oh, I'm not going to go there because I'm going to be in pain, but then you say, no, with Tylenol I can manage the pain, it won't be unbearable but it will be bearable, and you're going to go to that event, then absolutely. So you want to get ahead of the pain because the pain is not going anywhere. It will be there because of the arthritis. So you want to get ahead of the pain. Trying the right regimen, local management, systemic management, it's a fine balance. You want to figure out the least amount of drug with the most efficacy. So if you can do local treatments, gels, creams, heat, ice, brace, support, acupuncture, that will help alleviate some of the pain. And unfortunately, these are chronic treatments. This is on a day-to-day basis. Applying the cream every day, remembering to do it. It's a chore, but if it lets you get ahead of the pain, then you want to do that. Patches, so local treatment, whatever can help. Then going to the systemic treatment. Many people tell me ibuprofen helps me. Yes, absolutely, take it. There is a limit to how much ibuprofen you can take. If you're getting away with 6 tablets of ibuprofen a day, I tell them, add 2 Tylenol to it, and maybe that 6 will become 4 of ibuprofen. That is safer than 6. Taking lesser NSAID or anti-inflammatory is better than taking more. So trying to find that balance. NSAIDs are the most commonly prescribed drugs by us, anti-inflammatories. So they help calm down the pain, they help calm down the inflammation, work really well, but of course with the elderly population we have to be worried about their stomach, GI bleeding risk, kidneys when they're frail, and many of the patients have heart attacks, strokes, blood clots, and they are on blood thinners, so the combination again gives us issues. So it's again a fine balance. If you're going to be suffering, if you cannot take any other pain medication and you can manage with ibuprofen and you have a quality of life, then it's a fine balance. Do you want to take that risk or not? It's all risk versus benefits. If the benefits outweigh the risk, then absolutely. Because if you're going to be sitting and not exercising because you're in pain, you are increasing your risks of heart attack and stroke anyways. So you want to be as active as possible. There are over-the-counter anti-inflammatories like ibuprofen and Aleve. You want to be limiting to the recommended dose. Don't go above the recommended dose. That's where most of the problems happen when patients are popping several pills because they're in pain. Kidneys get damaged because of that reason. One of the other common things for elderly patients is when you are dehydrated. You don't want to take pain medication because the NSAIDs decrease the blood flow to the kidneys, and when you're already dehydrated, the kidney function, the blood flow is bad to the kidneys, and that decreases the kidney flow even more, causing renal toxicity. So if you're having diarrhea, you're losing water, you're not keeping up with the water intake, definitely remember not to take any anti-inflammatory. Tylenol is okay, but no anti-inflammatory or NSAIDs in those situations. The other common medications we use are nerve pain medications because many a times patients have neuropathy, tingling, numbness, burning, muscle relaxers for muscle spasms and pains. when there is a joint problem or more a back problem. In the back we only have bones, joints, ligaments, muscles, nerves, and tendons. So if there is a bone problem or a joint problem, anti-inflammatories help. If there is a nerve impingement or a nerve blockage, then the tingling, the numbness, the radiating pain, for that the nerve pain medications help. And then the muscles of the back, if they're going into spasm, we use muscle relaxers. Sometimes we have to do a combination of treatment to see what will work for the patients. What else about arthritis? So yeah, main thing is being as active as possible, doing joint specific exercises, local treatment, and systemic therapy. We also can give joint injections, again, which is local, corticosteroid injections into the knee joint, into the hip, into the bursas. Bursitis is very common. We are rheumatologists, so we don't do spine injections. Don't come to us for back injections. You need to go to the pain specialist or the orthopedic or the spine specialist, because we don't have a fluoroscopy machine, which is an X-ray machine, to see where the joints or where the nerves are going around and avoiding those spaces. So they do it under fluoroscopy. Even the hip joint, if you're doing the hip joint, not the bursas. We do the bursa injections, which is the side of the hip, the trochanteric bursas, but we would refer you again to orthopedic or a pain specialist for hip joint injections, because there are the big blood vessels of the femoral artery and the femoral vein, and we don't want to do a blind injection for those. Osteoporosis, unfortunately, also is a very common, I wouldn't say it's a disease, because it normally affects everybody as we age. It's just part of the aging process. Osteoporosis is where the bones become brittle and patients will fracture with just a small injury or a small fall. So the recommendations, the guidelines are after the age of 65, every woman should get a baseline screening, and based on the bone density report, if it's normal, repeat screening is recommended in 3 to 5 years. If the bone density shows osteopenia, then recommendation is in 2 years, and if it's osteoporosis, then you need a treatment right away. So after you were 65 and up, everybody, one of the most common things that many people ignore is taking calcium. Our bodies need 1200 milligrams of daily calcium to function, just to do the day-to-day function activities. If you are not taking 1200 milligrams of calcium on a day-to-day basis, it's not coming through your diet, then the body is going to rob it from the bones. Bones are the 99% reservoir of calcium. You're not giving enough calcium to your body, the body says, I have plenty from the bones, so they will rob it from the bones, making the bones weaker. So for those reasons, milk, yogurt, cheese, green leafy vegetables, these are the richest sources of calcium. You need at least 3 to 4 servings every day, which is like a cup of milk, a bowl of yogurt, a slice of cheese, and a bowl of green leafy vegetables. If you're getting 3 or 4 servings of this, you're good. You don't need to take a calcium supplement. Most of us don't. So you need to add to that. The minimum you want to take is 1200 milligrams. The maximum you want to take is 2000 milligrams. Most patients are recommended to take calcium. The only contraindication for calcium would be if you've had a history of kidney stones and they were calcium stones, then the doctor will tell you don't take calcium supplements for those reasons. The other cases would be when you have CKD, kidney stage 4 disease, your kidneys are not functioning, your GFR is below 30. That's when the nephrologist or your primary would say don't take extra calcium supplementation because it will lead to vascular calcification, leading to more problems. But otherwise, everybody should take calcium supplements. Same thing with vitamin D. Even though we are in sunny Florida, most of us don't go out in the sun without sunscreen. So sunscreen blocks the vitamin D. So we are not getting any vitamin D from our sun. And even though we go out in the sun, we are of course avoiding the bright sun, the afternoon sun. That's when most of the vitamin D is there. So if you're not getting enough sunlight, you need to take a vitamin D supplement. The body needs about 800 units of vitamin D. I recommend my patients to take anywhere from 1000 to 2000 units. Sometimes I find 1000, they're taking the 1000 but it's not replenishing it. So recommend 1000 to 2000 units of vitamin D. Uh, Exercise is important in osteoporosis for bone strengthening, for preventing falls. So exercise, weight bearing activities, 30 minutes of walking every day, I would recommend. Avoiding to smoke, avoiding to drink alcohol more than 3 units a day, which most people don't. So those are the other guidelines, recommendations to manage osteoporosis. Treatment is relatively simple. There is a pill, the recommendations were given for the pill to outweigh the risk. I know there are some risks associated with, many patients are like, oh, my dentist told me I cannot take any osteoporosis medication because I will have osteonecrosis of the jaw. Yes, the risk is there, but it's usually very low, and I usually tell the patients, let your dentist know if you're having any invasive dental work. Regular cavity cleaning, everything is okay. If you're having an extraction, any implants, any bridges where they're exposing the jawbone, that's when the risk of osteonecrosis of the jaw comes from. But maintaining good oral hygiene is definitely important, and seeing the dentist every couple of 6 months to keep an eye on that is important as well. There are several medications for osteoporosis depending on your risk factors, or we like to divide the patients into high risk or very high risk. One of the other common mistakes that some primaries do, not everybody, they're not the specialist for osteoporosis management. So many a times they miss some patients who need to be treated because the bone density says osteopenia. Some of the imaging places will mention osteopenia, but they will also give another measurement called a FRAX score, which is a fracture risk score. There are 2 numbers in there. It's called major osteoporotic fracture or a hip fracture, and they will give a percentage. So if those numbers are, the major osteoporotic fracture is more than 20%, or, it's not and, it's or, the hip fracture risk is more than 3%, you need a treatment. Irrespective, your bone density may say osteopenia, but the FRAX score says MOF is 22%, or the hip says 3.2%. You need a treatment, because what that FRAX score is adding to your value is your family history. When you're doing the bone density, a good imaging place will ask you these questions. Have you ever had rheumatoid arthritis or diabetes? Do you drink alcohol? Have you ever taken prednisone 5 milligrams or more for more than 3 months? Has your parent ever fractured a hip? Because these risk factors increase your risk of a fracture. So they add those numbers to calculate a FRAX score, which is in the next 10 years, if there are 100 people who have this score, how many will fracture? So 22% means in the next 10 years, 22 out of 100 people will have a major fracture. Major fracture is a arm, wrist, shoulder, spine, and the hip risk is the hip fracture. 3.2 means 3.2 out of 100, or 32 out of 1,000 people will fracture a hip. That doesn't seem a lot. 3 out of 100 will have a hip fracture, but hip fractures add a lot of morbidity and mortality to elderly population. That's why we take it very seriously. And the thing is, we want to prevent it. We don't want to, treat it after the fact. So you want to prevent, because this is a preventable disease. Unfortunately, it is difficult to convince patients because osteoporosis is a silent disease. Nobody knows they have osteoporosis unless I do the bone density, or you've had a fracture, fragility fracture. Fragility fracture means you had a fall and you fractured. But if you were 40, a young, healthy person at the age of 40, and you had that same fall and you would not have fractured, and you fractured because you were old, because your bones are brittle, that's called a fragility fracture. We don't count fractures of the fingers, the toes. Many patients will come to me, oh, I walked into a cabinet and I fractured my toe. We don't count those. Skull, because it requires a big trauma to fracture the skull. So skull, fingers, toes are kind of excluded from fragility fractures. But any other joint, if you fracture with a minimal trauma, with like, oh, I would not have fractured it but sometimes some patients tell me, no, the trauma was too much that I would have fractured no matter what, then that is not considered a fragility fracture. So you want to take that history as well. Many a times, unfortunately, the education is going around. many orthopedics, at least 10 years ago, I want to say, they would treat hip fractures. You know, they would replace the hip, but never tell the patient, go see a rheumatologist or your primary care to get treated for osteoporosis. Even now, I think there are few who still don't do that, but education is happening. But you need to be aware if any of your friends have a spine fracture, a fracture in the back, or they just fell and they fractured, or a hip fracture, and they got joint replacement, they need to see rheumatology or endocrinology. You know, we both manage. This is a disease that both specialties can manage for osteoporosis. So that's very important not to miss. So as I was saying, one of the things that primary cares can miss is when the bone density says osteopenia, but the fracture risk score is high, and they don't know, they are not well trained. Of course, primary cares have so many things on their plate. You know, they're managing your high blood pressure, diabetes, and you know, so it's not fair for them to know everything. So sometimes they may miss that, but you want to look at those numbers and see if the number is more than 20% for major fracture and more than 3% for hip, you need treatment. Definitely start right away with the calcium and the vitamin D, and you know, see your primary. They can at least get the process started for the oral pills. Of course, there are much better medications now with anabolics. Anabolics are bone building medications. They build bone, so they are not trained or well aware of those medications. You would need to see a rheumatologist or an endocrinologist to get started on anabolic therapy. So I usually reserve my anabolic therapy when patients are very high risk for fracture. So who are the very high risk? When you have fractured already. It is said 1 in 5 people will fracture in the same year again once you've had one fracture. So you're considered very high risk. Second is you've been on some treatment. You've done a bone density, but the bone density has become worse. That means you're not responding to the treatment. So that is, again, we classify those as very high risk. And the third is when your T-score, which is on the bone density, if the numbers are very high. So Z-scores are comparing you to your peers. So on the bone density, there's a mention of a T-score and a Z-score. Z-score is your peer, which means they're comparing your scores to 70-year-old population, versus the T-score, they're comparing your bone mass to a 40-year-old healthy woman, where the peak bone mass is happening. So as we know in statistics, standard deviation, 0 is the norm, +1 means you're on the plus, better than the normal, +2, and then there is -1 standard deviation and -2.5 standard deviation. So when you are between 0 and -1, you're considered still normal. When you're between -1 and -2.5, you're considered osteopenic. And if you're more than -2.5, you're considered osteoporotic. And if the T-score is more than -3, we consider severe osteoporosis. That tells me the bones are really brittle. So those are the 3 reasons we would recommend, anabolic therapy or bone building medication, because the foundation is weak. You have holes in your bones. They're very brittle. So you want to build the foundation. You want to lay more good bone. So there are only two types of medications. There's injection, which is a daily injection the patient does at home for 2 years. And then there is once a month injection for 1 year that builds bone. So both these medications are recommended. Of course, patient factors, I don't like to inject myself, or cost factors, which is one of the biggest factors nowadays, if you can afford the drug or not, and patient preference, all these play into the role about which drug is the right drug for you. After the anabolics is the antiresorptives. That's the one that we most commonly use if patients, cost is a factor, or patients don't want to do injections. In the antiresorptives are basically blocking the bone-eating cells. In our body, we have bone-forming cells and bone-eating cells. So they're blocking the bone-eating cells to not eat away more bone, so that slowly over several years you will slowly build more bone and not have more bone loss. So one of the most common oral medications would be the Fosamax or the alendronate that primary care can get started. That's once a week. Then there is once a month options as well, which is Boniva or Risedronate or Actonel. Those are the other options which are available as once a month. And then there is Prolia, which is every 6 months. It's again an injection given in the arm or the belly. It is a little bit stronger than these medications, but again, it comes with its own side effect profile. Of course, it's costly. Many of the patients, unfortunately, now are moving to what we call as Medicare disadvantage plans, which don't cover all the treatment options. When the broker or the insurance rep is selling it to you, they'll say everything is covered at a price. It is covered.
I forgot
Yes.
the small print.
Yes, at a price higher. So if you have regular Medicare and a supplement, yes, these drugs are covered 100%, but if you don't, you have a Medicare disadvantage, only 80% is covered, 20% is patient responsibility. So it comes out to be about $350 for the Prolia injection every 6 months. So if cost is a factor, then we recommend the oral pill. There's also an IV option of the oral bisphosphonate, which is once a year, given intravenously. The good thing about the bisphosphonates is if you miss it, if you skip it, it doesn't do any harm. Prolia is a good drug. It is better than the bisphosphonates. It's more potent. It does a whole lot better. Of course, comes with a price factor, and you cannot miss it or skip it. It does cause rebound fractures, rebound bone loss. In the trial, 10% patients who skipped the dose were found to have fractures, rebound fractures in the spine. So we want to avoid patients having that. I don't want to do any harm. So I always tell my Prolia patients, never ever skip or miss it. Now we've introduced a protocol where patients are if they're missing the dose, we call the patients and tell them, hey, you want to come, reschedule, and if they don't answer, we send the patient, the primary care, the message saying they have missed their Prolia. Make sure you're putting them on the other oral pills, at least, to prevent that bone loss or prevent that rebound fracture. I think I have 20 more minutes. I think I want to stop so that I can take questions, unless you guys have any topic that you want me to talk about.
I have a couple questions.
Yes, absolutely.
Do you cover all the autoimmune diseases, or is that usually with an endocrinologist?
So autoimmune is a wide spectrum. There is
Right.
rheumatological autoimmune diseases, and there are autoimmune diseases that are not treated by rheumatology, which are like thyroid. Hashimoto's
Right.
is an autoimmune disease, but it's a thyroid or endocrine autoimmune disease. Then myasthenia gravis is a neurological autoimmune disease. So there are other autoimmune diseases across all the spectrum. We treat mostly the rheumatological, which affects mostly the joints, as you want to say. So rheumatoid arthritis, lupus, psoriasis, Sjogren's, scleroderma, those are our autoimmune diseases.
Okay, I was wondering about Sjogren's and lupus.
Yes.
Okay. And then going back to taking calcium, I've read that it increases absorption if you take it with magnesium as well.
Yeah, magnesium, vitamin K, that helps absorption from the gut. Yes,
Okay,
it does.
okay, thank you.
In addition to the D3,
Yes,
so if you take magnesium, it'll help absorb it.
yes. And vitamin K too.
I'm going back on my
You
notes.
talked about shots. Do you ever give shots in the knuckles?
Yes, the MCPs, yeah, if they are swollen, so osteoarthritis of the hands is one thing I didn't cover, but that's very common, where you have joint swelling, bony swelling. So the one way to differentiate rheumatoid arthritis and osteoarthritis is the knuckles. These are the MCPs, the metacarpophalangeal joints. These are the ones that are affected in rheumatoid arthritis.
I'm talking about.
Yeah, these are never affected in osteoarthritis. So if you only have the PIP, which is the middle joints, and the last ones, which is the DIP joints, swollen and painful, that is regular osteoarthritis of the hand. I have, of course, gotten these easy referrals for me, when patients come and say, oh, my primary said you have rheumatoid arthritis. And I look at the hands, I'm like, osteoarthritis of the hand. It's an easy, just visual diagnosis for me. When their knuckles, the MCPs are not involved, and only the PIPs and the DIPs are involved.
Do you still treat people with that?
Yes, so there is a severe variety which is called erosive osteoarthritis, which is kind of in between osteoarthritis and rheumatoid arthritis. So sometimes we do use rheumatoid medications for those kind of severe erosive osteoarthritis. There is a newer technology like low dose radiation therapy. When patients are really in pain, nothing helps for them. Thankfully, most patients have the arthritis. They're not painful, but 10-20% of the patients, they have the bony swelling and it is really painful. So in those situations, we use medications like hydroxychloroquine, sometimes even methotrexate that we use for rheumatoid. We use them for osteoarthritis. And as I said, low-dose radiation therapy has been proven to help some recently for osteoarthritis of the hands, or what we mostly call, it's called erosive osteoarthritis of the hands. Yeah.
Interesting.
Can you talk a little about psoriatic arthritis?
Yes, so psoriasis is a very common autoimmune disease. You know, it's just the skin rash. It's worse than eczema. In eczema, it's just redness, but in psoriasis, there will be scaling. It can affect the scalp. There are different types of psoriasis. You know, there is scalp psoriasis, plaque psoriasis, which is the most common, that affects the knees and the elbows. Then there is palmoplantar psoriasis, where the psoriasis affects the palms of the hands and the plantar surface of the feet. And then there is psoriasis, erythrodermic psoriasis, which is like small red dots all over the body. It can be a medical emergency because the psoriasis is involving almost the whole body. So when you have psoriasis, 1 in 3 people can develop psoriatic arthritis. Not everybody develops it. So whenever patients who have psoriasis are referred to us, you know, we are playing the investigation. Is this inflammatory arthritis or this is degenerative arthritis? Because at age 60 and 70, everybody is bound to have some component of degenerative arthritis, which is I'm aching, my joints are stiff, I'm hurting all over, you know, but we are differentiating those factors, like are you worse in the morning? Are you swollen? The more you move, do you feel better? But sometimes it might be tricky because, you know, they have so much degenerative arthritis that they are not giving me maybe the right answer. So we have to do the blood work, do x-rays, sometimes even MRI to confirm if it's only osteoarthritis or it's a combination of psoriatic inflammatory arthritis and osteoarthritis causing the pain for the patient.
And what kind of medications do you use for it? When do you decide to treat it with them?
So the decision to treat is always risk versus benefits. So if it's really mild, manageable, the first line of treatment for psoriatic arthritis is anti-inflammatories, NSAIDs. Round the clock, every day, full dose prescription anti-inflammatories. So if anti-inflammatories don't work, then the second line is DMARDs, or disease-modifying anti-rheumatic drugs that we use for rheumatoid arthritis, like methotrexate, sulfasalazine. Sometimes we even try leflunomide if the rash is not terrible, if psoriasis is not the worst. And then after DMARDs, we jump to biologics, which are the stronger immunosuppressive medications. In the psoriatic world, we have tons of biologics. Thankfully now they're very safe. They don't have much black box warnings or risks. Because these are biologics, we still tell the patients that they will suppress your immune system. But some of the newer ones like Tremfya, Skyrizi, Taltz, Cosentyx, when you look at their risk at their placebo, comparing them against the placebo, the infection risk is not terrible. They're almost similar. But we still warn the patient that these are immunosuppressive medications, so they may suppress your immune system. And depending, if you have psoriasis and IBD, or inflammatory bowel disease, sometimes go hand in hand. There is a gene called HLA-B27 gene that can cause both these diseases. So if you have inflammatory bowel disease or ulcerative colitis or Crohn's disease, then we prefer some biologics over the others. Like Taltz and Cosentyx don't have IBD coverage. They don't help the gut, and sometimes they may even make the gut worse. So we try to avoid those drugs, and we may prefer something else that can cover the gut also.
Interesting.
I might have missed this because it was late.
Yeah.
But should men be taking calcium, and should they get bone density?
Yes, absolutely. But thankfully, men's bones, because they continue to have testosterone, so they are not, they don't lose bone mass like women do after menopause. Our problem is menopause. We hit menopause at 50, the estrogen's gone, the bone is declining. So men, very rare to have osteoporosis. It's mostly the patients who have prostate cancer or who are on anti-testosterone therapy. Those are the ones that need to be screened for osteoporosis.
Are you familiar with stem cell therapy for treating rheumatoid arthritis?
So there is literature they're trying to do therapy, I don't think we are there yet to say it works. I know many orthopedics do, platelet-rich PRP injections and stem cell therapy. I personally, I don't know much about it because I have not done it. It comes at a cost. Sometimes patients ask me, should I do PRP or stem cell therapy? I will tell them, there is some literature supporting it. Again, it's like a bell-shaped curve, right? Some respond, some don't respond. And nobody knows where you are in that bell-shaped curve. Are you going to be the one of those that is going to respond beautifully to the PRP and stem cell, or you're not going to respond? So it comes at a cost. I said, if it was that good, they would have submitted for FDA approval and gotten the FDA approval. It's not FDA approved. So if the cost is not a factor, and I know when you're in pain, you want to do anything to get rid of the pain. So if cost is not a factor, if you're okay, I don't want you to take a loan out and then do the stem cell saying this is going to change my life. If cost is not a factor, you're okay with losing that money and you're in pain, yes, go ahead, try it. But if cost is a factor, you want to, do the due diligence, because you will talk to 50 people who said, oh, I responded. And you may talk to 2 people who said it did not respond, I did not respond. Nobody will give you a guarantee you're going to be among the 50 or the 2.
Have you heard of using ivermectin to treat RA?
No.
No.
There is no studies for that, no.
What's your thoughts about doing some of the exercises, like if you have bad knee joints?
Swimming
you're trying, like walking in the pool to take off
Yes.
some of the stress.
Yes,
of
for
the
knee,
in the
we
pool.
definitely don't recommend walking on level ground. We don't want weight-bearing activity for the knee joints. We recommend more swimming and bicycling.
Yeah, or like walk.
In the pool, yes, yes. Yeah, pool exercises are great because they don't put pressure on the joints and
You're
they
still
strengthen
moving
your
the joint.
muscles and ligaments and yes, absolutely. Any more questions?
If you've been diagnosed with osteoporosis, no, I'm really there, I'm sorry now. Does the taking the medication, I did the Prolia, then the Evenity, that Prolia, does that cause some of my joints to lock up, like my fingers? Does that cause some of it?
No, there is no truth to the arthritis. There was, when you look at the data when they did the studies, joint pain was the most common problem that was complained in the placebo arm and in the Prolia arm. It's because the age group that we give the drug to.
Oh, you're just ugly to me now. Okay.
Yeah, so it was in 100 patients, I think 30% complained of back pain in the placebo group and in the Prolia group. They always compare it, was it statistically significant to blame that pain on Prolia, and it was not.
You know those shots hurt, right? So it's Evenity. I'm just letting you know.
Yes,
Frankly
yes.
speaking, you know.
Yes, some people, not everybody, there are some who say it hurts, then we go to the abdomen then, we don't give it in the arm.
I was putting my nail in my finger to transfer the pain. Those Evenity shots hurt so because I had to take 2 shots.
Right, it's 2 injections.
Yeah, it's great fun, yeah.
Yep.
Tell me about trigger finger.
Trigger finger, it's a regular arthritis problem where, the tendon, you have pulley mechanism in your fingers, there are several pulleys that are going there and the tendon is going in. So sometimes because of arthritis, the tendon thickens up and then it can't go in the pulley. So this is the pulley, it's easily going in, going out, that's why I'm able to open up. But sometimes the tendon thickens up and now it can't go in easily and can't come out easily. So that when it locks up. So usually the nodule can be felt in the palm. The treatment is, cortisone shot into the nodule to calm down the inflammation. The nodule disappears for a few months, then, the trigger finger is released and it gets better, and then over months again, the thickening happens and it locks up again, and then, it's a continuous process. The surgery is the last answer if it's happening too often. Yeah.
So my husband just said something to me and I was like, I don't think I heard that. Did you say something about treating
Low dose radiation for the knuckles,
Yes, osteoarthritis.
for osteo?
for osteo,
Yeah.
but it can be done for RA too or no?
No, there's no study on RA for it, yeah.
So what are the medications for RA?
again, the step therapy. So DMARDs, or disease-modifying anti-rheumatic drugs, are the first line. So hydroxychloroquine, again, people might have heard it during the COVID, thinking that it could treat COVID. Later, when there were more bigger randomized controlled studies, it didn't help COVID. So hydroxychloroquine is one of the mildest drugs that we have. We use it very commonly for rheumatoid arthritis. The moment patients have lupus, we give it to them. It's life-changing for lupus patients and Sjogren's patients. Usually helps with rashes, joint pains. Mild to moderate disease, we use hydroxychloroquine. When they have more moderate to severe disease, then we go to methotrexate. That's the gold standard usually for rheumatoid arthritis. And then if methotrexate doesn't work, we do have other disease-modifying anti-rheumatic drugs like leflunomide and sulfasalazine, depending on how bad the symptoms are. Then we can jump to biologics, anti-TNF, which is like Enbrel, Humira. These are the drugs that have been in the market for several years. And then now we have several other new drugs, oral JAKs, interleukin-6 inhibitors, and so many and so forth. So we have to find the right drug. Again, cost, patient factors, injections, oral pills, infusions, all of that, comorbidities, if you have diverticulitis, if you have COPD, some of these factors determine if I can use one biologic or the other, melanoma history and things like that. Yeah.
So thorough medical history is really essential when you're
Yes.
treating a patient.
Yes, absolutely. Any more questions?
Where am I gonna get finger exercises? Can I just go on?
Yeah, look on YouTube for
Okay.
Yeah.
I
look-
didn't know it was a big deal or something.
No, if you're a good follower, you can look up on YouTube physical. I tell my patients, I know physical therapy costs a lot of money, going 2-3 times a week. Sometimes it's expensive. I tell the patients, go on YouTube, look at physical therapy exercises for that particular joint. If it's working, good. If it's causing more pain, that's the wrong thing for you.
Stop.
We have to go back.
You're pretty quick on that, aren't you?
Yeah. Yes.
Well, thank you so much,
You're
Dr.
welcome.
Panthulu. We do appreciate your time.
Absolutely,
I've
yes.
learned a lot, and I'm sure my other mates here have as well. We
Yes.
appreciate everything.
Yep.
And
Thank you.
do you have any business cards?
No, I did not bring any. So,
Okay.
yeah, I'm one of 6 physicians. We do have 5 offices from Tampa, Brandon, Sun City, Lakewood Ranch, and Venice. I work 2 days out of Sun City, 1 day in Lakewood Ranch, and 1 day in Venice. But my colleagues, Dr. Fitzgerald, Dr. Joseph, they are also in our Lakewood Ranch and Venice offices. So, yes.
Okay, I know where your practice is. You're right.
Yes.
In the front door of the medical office building.
Yep.
Right by Lakewood Ranch Hospital.
Yes,
So,
yes.
all right. Thank you so
I
much.
hope you guys don't need me. Right? Be healthy.
Exactly.
Yes, I hope you guys don't need me, but if you guys need me, I'm there for you guys.
So, bottom line, exercise.
Yes, yes.
Helps to prevent it, and if you have it, then it helps you with pain.
Yes, absolutely. Thank you so much, guys. Have a good day.